Good afternoon, morning, everybody. I'm from Ghana. I'm Verna. I'm a clinical oncologist, radiation and medical oncologist at the Korlebu Teaching Hospital, and I'm going to talk about colorectal cancer in Ghana. So this is actually a little bit about Ghana. Ghana is a West African country. It's democratic with 30 million people. It's a low to middle income country. We have 2.8% GDP growth rate. GDP per capita is only 2,000 as at 2003. We have an 85% GDP to debt ratio, shows you how we are in trouble, with less than 7% of expenditure on health, and communicable diseases take stage. We have a national health insurance that concentrates on breast, cervix, and childhood leukemia, but that is changing over time. So just from the global data to say we don't have very strong registries, we do have some population registries that are collecting data, and that is the basis of the data I'm presenting to you at from GlobalCan. And it showed that among the cancers in Ghana, the top 15, colorectal, unfortunately, is about number 10 overall. But when you look at male versus female, for the males, it is number 5, but females is actually number 7. And you can see there's almost an equal male to female ratio. So in terms of epidemiology, 3,000 cases were recorded in the year 2000. Obesity, alcohol, and red meat from the literature shows to be one of the risk factors for developing colorectal cancer. Unfortunately, more than half present with that locally advanced disease. The most common site is the rectum, left-sided, and a lot of left-sided and high-grade tumors were observed. Symptoms average about 1 year because most people present with hemorrhoids and are treated with the traditional healer. So that delays the diagnosis, and unfortunately, our health system is not sensitive to the symptoms of colorectal cancer. So it takes quite a while, even in the health system, to get finally referred for a colonoscopy with symptoms. From a pathology report, almost 90% were adenocarcinoma. We still had a few neuroendocrine tumors coming up, and a repeat study. This is about 5 years ago. A repeat study shows about the same thing. And the study that was done 10 years ago, unfortunately, showed that 40% had MSI high, 38% MSS stable, MSI stable, 32% KRAS mutation on exon 1 and 2, no BRAF mutations, but the number was only 200. So we need a bigger study to tell us what it is. And looking at the age distribution, this again was 5 years ago, shows that we still have quite a high number above the age of 50. Unlike what the literature is showing. This is 13 years ago, but I went back to look at my data from my institution, which is one of the largest referral centers, and unfortunately it's the same. We don't have that many young population presenting with colorectal cancer, and single digits of 6, 8, and 9 per year. But this is just to say it's the tip of the iceberg because we don't have a good cancer registry. The number of cases over the trend has been increasing like everywhere else, and the survival is not that great overall. The 15% about 5 years ago was 15%, unfortunately. But like everywhere else, stage 1 does better than the subsequent stages. Stage 2, stage 3, stage 4, and 3 were not that good. But that was before we did all these molecular testing and also attempted to treat the patients with targeted therapy. So this might change when we update our data. And this is a study that shows the survival of colorectal cancer in sub-Saharan Africa, which was just presented a few years ago, and it showed 2022. And look at the main gap was a lack of evidence in survival pattern in sub-Saharan Africa. And looking at all the studies, 1 year, 3 year, and 5 years, however, was not that great. 1 year was 75%, 2 years was 38%, and 5 years. So the survival of colorectal in sub-Saharan Africa is low, just the same as what we have in Africa. We need to change this over the period of time. Screening in Ghana is not structured. There's no screening program. The National Health Insurance does not cover for screening services. The cost of screening colonoscopy is a deterrent to implementation. There are a few screening facilities with few specialists in the major centers in the urban cities. We have fecal occult blood tests and immunohistochemistry tests for feces as well. The primary care workers have a low appreciation of symptoms and signs. Genetic testing in high-risk families is fraught with cultural consequences. The implications of being diagnosed as having a familial disease has a lot of implications. So I think that's why we still have some limitations there. A lot of people use alternative medicines, and the lack of education and community barriers. That is a major problem we have from a recent update that was done about a year ago. Unfortunately, there's low prioritization by governments and the health system despite the fact that we have an NCCP, which is actually not really implemented. But we are hoping that in a few months to come, screening will be implemented across board for people above the age of 50. So the current trends in diagnostic infrastructure for pathology, we have private labs that do next generation sequencing, everything that you ask for. We have tumor markers in the regular labs, FIT, FOBT in the regular labs, H&E, report on circumferential margin, that's a must over the years. So it depends on where you get your report from, unfortunately. Immunohistochemistry, again, private, some of them are exported out of the country, which could delay results. But we do IHC for DMMR, HER2, and then EGFR, especially. EGFR, that means we can't tell the specific mutation, but we can tell that there's mutation. We don't know what that means, but so far we've been using it somehow to treat some of the patient. It kind of like seems it's like a tryout, basically. But this is the minimum that we can do if you can afford the NGS. It's also an ethical issue when the patient can't afford the drug to go ahead and do the full test. So that's so when it's positive, then we have that discussion and ask for further NGS. Imaging, there's increase in imaging equipment in the urban areas, ultrasound, chest x-ray, diffusion-weighted MRI is what we use most of the time. We do have an endorectal coil in the main hospital, in the Korlebu Teaching Hospital, my institution, and another private institution. And the rectal ultrasounds are not commonly used, unfortunately, but we do have CT scan, bone scan. The PET scan is coming up in 2025, and we do have image-guided biopsy. The current infrastructure for surgical capacity, we have general surgeons. There's no surgical oncologists, but we have surgeons who do high-volume colorectal surgeries. Right now, we have a minimum of 12 to 15 lymph nodes dissected. There are intersphincteric dissections, there are perianal colostomy. Hepatic and lung resections are not done for stage 4 right now. It's even for those where they can, it's quite expensive. So that's our major headache. We have no surgical clips are placed. And with patients who have high risk polyps, total colectomy is frowned upon, not by the patient, but actually by the surgeons as well, which actually is also a big problem. The private centers tend to be lone wolves. They don't discuss the cases with anybody. So we really don't know. We get the referrals from them after the fact. But there's a new accredited program under the West African College of Surgeons for colorectal surgery and surgical oncology. So we think that overall, this goodwill in my institution will spread to other institutions. And there are also some North and South collaborations for University of Michigan and other universities to improve the training. In terms of systemic therapy capacity, we are clinical oncologists, both in radiation and medical oncology. We have high volume in academic centers. Molecular profiling on the patient is not routine. I've explained the reason why. Genetic counseling is not routine either. Most of the conventional drugs we have are generics, capecitabine, 5-FU, CPT-11, oxaliplatin, but we prefer K-POP because it's less toxicity. We give 5 cycles followed by 3 cycles of capecitabine. Furanox is actually rarely administered because it's very expensive and most of our patients don't have a very good performance status. So we have zoledronic acid, and the targeted therapies available are bevacizumab, trastuzumab, cetuximab, PD-L1. Regorafenib are actually on order because of the cost. It's not on the insurance system, and our buying capacity is quite low. Except for radiotherapy capacity, I think that's been repeated over, but that map there just tells you the paucity of radiotherapy in Africa as a whole. Ghana has 3 centers, 2 down south and 1 in Kumasi, which unfortunately has been down for a couple of years. They are all linear accelerators, and we have a few cobalt systems as well, which helps when we are in trouble in terms of with our power and downtime. We have geospatial challenges with access, and we have CT simulation, 3D conformal radiotherapy, intensity modulated with image-guided radiotherapy, and we use 2D a lot for palliative radiotherapy. Our management options now, we are gearing more towards total neoadjuvant for rectal tumors. We started that even long before the data came up because of systemic challenges. We didn't have a choice. The wait time was too long, so you started with your chemotherapy. But then long course is preferred over short course. The only reason that most of them are actually locally advanced. They're still not convinced that short course is equivalent to long course, but I think we are going to look at our data to state that. We do a lot of IMRT with simultaneous boost, and we give concurrent capecitabine. And the challenges we have are when the patients are sent post-op, there are a lot of positive margins and surgical clips, so we need to review. That's most of them coming out of the teaching hospital system. And we use a lot of palliative RT. Occasionally for patients who have limited liver metastasis, we use targeted IMRT, something like SBRT, but not quite. So our MDT is almost about 5 years old. where we do it virtually. We have both public and private institutions here that they don't tend to bring any patients, they're just listening. Unfortunately, we have our colorectal surgeons, clinical oncologists. Most unfortunately are presented post-op, even for rectum. And most of them have emergency surgeries for obstruction before they enter the system. So most of the patients, unfortunately, a few patients are discussed prior to any surgical intervention. Again, like I said, there are no molecular genetic profiling. Family histories are unknown because it's a taboo to say you have cancer in your family. A lot of emergency surgeries with metastasis. We hardly have neoadjuvant for colon cancer. The timing of surgery post-total neoadjuvant can also be problematic. Of course, when it was just 5 days, it was almost impossible to get the patient on the machine in 5 days. But now that the duration is now longer, we actually tell that, and we're happy that it is enough time to schedule the patient. Of course, we do imaging to make sure the patient is responded. A few patients are now preferring not to have surgery, and we don't know what that means over the period of time, but I think our data will find out. So we do most chemo first, followed by chemo RT because of our system. And this is a study that published 5 years ago looking at the association of clinical parameters with survival. And you say this combined both colon and rectum. So the results are a little bit mixed, but those who had chemo, those who had both chemo and RT tend to have a better outcome than those who did not. So I think all that comes together to say why we should actually go with guideline concordance care. And I think this will change on our next updates. In terms of palliative care and survivorship, there's a high loss to follow up, which is a hindrance to survival statistics and quality of care. There's reduced access to palliative care workforce. The local training programs for physician and nurse specialists exist, but we hope that we have to expand this for colorectal cancer, especially. We have clinical oncologists to help them through the journey because we tend not to talk about the fertility issues that come along with pelvic irradiation, not even just that, but even erectile dysfunction, female and male. We don't seem to tackle that. We seem to concentrate on that for prostate cancer and gynecological cancer. So it's another area that we need to move in. Morphine is readily locally available for those who need pain medication. There's no really structured survivorship program or research, unlike breast cancer. So I think we need to change that as well. There is dietary support and GI specialist support when available. And basically, in conclusion, Ghana is a low to middle income country with infrastructure to improve colorectal cancer. We do have almost everything that is basic, but colorectal cancer is not prioritized in the national policies across, right from early detection, screening, all the way through to survivorship. And geospatial limitation to guideline concordant care is available in a few centers, so therefore the rest can't really join in. There's limited research in this field, and that should be highlighted, especially patient-reported outcomes. Molecular profiling data from private institutions and that's research, because they usually don't give you back their information to be able to collate to give what the landscape is. But I think very soon we will do that. Thank you very much. I'm ready for any questions.
Thank you so much, Dr. Verna, for this very comprehensive introduction to colorectal cancer care in Ghana. So I want now to talk a bit more about screening strategies in Ghana. Can you go back, please, to that slide on screening that you showed us before? You mentioned about cultural beliefs and how that cultural beliefs impact the uptake of screening programs. So what do you think, how this can be changed? Maybe some educational programs or
I think that's
at least can be addressed, right?
Yes, that is the first thing, education. Education,
yes.
education, starting from the healthcare worker, from the lowest level of the healthcare system. I think that is there, because even just educating your patients, you get a lot of symptoms coming out of that conversation. You understand? And then awareness about colorectal cancer. I think it's something, because it's something that is quite common now compared to first. We don't have the data, but it's obvious that it is a problem. And the sad part is that we could increase the number of patients who have early stage disease. That increases the survival. The survival we had for 5 years was 87%. So I think we can improve our survival overall, improve the quality of life of our patients if they can be diagnosed early. But the healthcare worker doesn't seem to be aware, or even screening. So I think that's what we need to tackle. Education, education, education. You're actually right about that. In terms of cultural barriers, it tends to do with female. It's kind of like it's a little bit of a a taboo examining a female or a male. Taking feces to the lab is a little bit of still a taboo, but things are getting much better. But again, it can be overcome with education, the necessities of that. At least that's easier than a colonoscopy. For now, there's not much. There was a study in Nigeria that showed that the uptake of the FIT test or the FOBT was not as good as the colonoscopy. But the colonoscopy is very expensive and not easily readily available to our patients. So we need to repeat these tests, maybe in a more randomized fashion, including the patient's aspects to see how they feel about these tests, those who've gone through it and those and the family members as well. That will give us our answers, how to tailor our treatment in terms of our context, what will be acceptable to our patients.
I see. And I'm curious, are there any kind of organizations in Ghana that take care of this kind of issues, like they spread awareness and trying
There
to
is, but
make a
yes,
difference?
there's a lot of lobbying for breasts. So I think that's taking center
I see.
stage. So you are actually right. We need to move into, I always say breast is not the only cancer. We need to move into the other cancers where we can really make a difference with screening. We all talk about screening of breast cancer, how it saves life, but screening of colorectal cancer can also save a lot of lives. So I think it's something that we need to really gear on, maybe make applications to the ministries or maybe the NGOs that talk about breast, we can extend for them to start including colorectal cancer, as the agenda.
Absolutely.
I think that's the easiest thing to do, actually.
Absolutely.
That's the low-hanging fruit. That's the first thing we need to do. Yes.
100% agree, because in case of cancer prevention is the key. In most cases, it's the best solution. So now I want to invite our panel members. Maybe you have some suggestions how that can be implemented to improve screening rates in underserved populations. Dr. Kasi, Dr. Abu Alfa, Michael, if you are still here.
Well, first, thank you so much, Gemma. And Verna, always nice to see you, and impressive work as always.
Hi. I didn't know you were there.
Good to see you. Well, I mean, to start, I mean, to be fair, we have to give you a lot of credit. The mere fact of acknowledging what are the limitations, this is by itself is a success. And what we are struggling with, and you are part of as well in the continent, is the awareness and the access. And we're kind of dealing with this same thing with liver cancer, as you know. And my question is, we had an exercise we're still working on, and you're part of as well, trying to go into the alternative medicine approaches and see if the first touch point for patients or potential patients is actually in that setting, and how can we really ensure that we are engaging with our colleagues in the alternative therapy approaches that can travel from alternative therapy to supportive care to magician to priests to head of tribes. How can we really engage them enough to really know that the screening is critical?
I personally think that we can go into the churches because that's what we do best. And also because that is the first stop when they have the symptoms of hemorrhoids. It can't be everybody, but we can start from anybody above the age of 50, needs further investigation. I think it worked with, postpartum hemorrhage. There's a study like that. And when they roped in the traditional healers, it actually reduced the number of patients who died from postpartum hemorrhage. But we all don't look at it as an action that we could do for cancer care in low to middle income. It's our first point of care. We can't even educated people end up going in that direction. So I think it's something that the ministry has to take up. Unfortunately, we hardly have that many private people, so we have to go through the ministry. But I think we can start from the civil service organizations. I think they're the first step to lobby, to have this change. So we have to encourage our NGOs to take up colorectal cancer as part of their fight. I think this is important. Something that we have overlooked. We admit that, yes.
I just wanted to quickly comment again. Congratulations on all your work. Having grown up in Pakistan and still in touch with family friends who get diagnosed with, colorectal cancer or other cancers, I think it's humbling to note that even the basic, genetic testing and stuff are still not available in a lot of countries, and access is an issue, cost is an issue. Everything comes out of pocket, so a solution that might be a solution for a country like United States. Even here, colonoscopy coverage was an issue till advocacy from the Alliance and Fight CRC and some of the other foundations. So as we come up with solutions, whether it's NGS testing, liquid biopsies, other aspects of treatments, I think we have to keep in mind, is it only a solution for an average patient in the United States, or is it going to be also helpful for patients globally? So I think I give credit to the OncoDaily and the Global Cancer Movement folks to have speakers and a representation from colleagues like you who are in settings where not every solution that we have is an option for the patient there.
Don't forget to like, comment, share, and subscribe to OncoDaily on YouTube. Hit the bell icon to stay updated.